just last week said climate change and its primary driver, burning fossil fuels, have created an accelerating health crisis. The health impacts in the United States are far-reaching and predicted to increase in the coming years. These impacts include heart and lung disease, infectious diseases, heat-related illness, poor pregnancy outcomes, sleep deficiencies, adverse mental health impacts, injuries, and death. Climate change also affects health through disruptions in healthcare delivery, education, employment, and other social systems, population displacement, and societal-wide economic harm. Policy decisions rooted in structural racism and economic injustice place many communities at even greater risk. So we will hear from each panelist first, and then the task force members will be able to ask questions. I think we can put questions in the chat, and we'll get to them as we carry through the conversation, and we're also welcoming questions in the chat from others as well. So today we are happy to be joined by Liaw, the Candidate Y and Lyndia Harvey Chair in Child and Adolescent Psychiatry and Chair of the Pediatric Mental Health Institute and inaugural Mental Health in Chief at Children's Hospital, Colorado. Ruba Basu is the Chief of the Air and Climate Epidemiology Section of the Office of Environmental Health Hazard Assessment of the California Environmental Protection Agency. Parenda Khatri is Chief Clinical Officer at Cherokee Health Systems, a comprehensive community health care organization in Tennessee that is a federally qualified health center and community mental health center. And Malaika Ludman is a birth doula and certified lactation counselor who holds a master's degree in public health. She's program coordinator for Birthmark Doula's collective Infant Ready program. Thank you for joining us here today. And we'll begin with Ron Lee.
Great. I think Antoine's here too, if you want to say hi.
Hey, hi, Antoine.
Hey, how are you guys? No, sorry, I was about a minute late. I was actually testifying on the Hill. So appreciate everyone. Welcome. We're excited about it. We're ready to hear our speakers.
Great. Well, thank you all so much for having me today. I did write out my remarks because we have 5 minutes. So I'm Joe Waters, co-founder of Capita, was my busmate this fall as we drove through the Badlands and the Pine Ridge Reservation in South Dakota earlier this fall. And through otherworldly landscapes and the Sioux tribe's ancestral homeland, he asked me about the impact of climate change on child and family mental health. I'm not a climate expert, but I am a child and family psychiatrist. I'm the mother of 3 and now mental health in chief for Children's Hospital, Colorado. Contributor to greenhouse emissions through my own work and family travel and life, an equally concerned citizen and parent on the planet. 20 years ago, during medical training in Houston, I witnessed up close and responded to multiple tropical storms, hurricanes, and flood disasters. I was an early career child psychiatrist in New York City during Superstorm Sandy, when both of our hospitals that I worked at, NYU and Bellevue Hospital, the city's flagship safety net, were evacuated and shuttered for months, displacing patients, healthcare workers, and thousands of New York City residents, including many children and families. Following the first few years of COVID, my family and I moved across the country to Colorado. We pulled up in our moving truck in Denver. The region was shrouded in smoke from wildfires blazing across the west and continuing to struggle with droughts, water shortages, and an uncertain future for the Colorado River. In December of last year, as I onboarded in my new role as mental health in chief, the Marshall Fire blazed across the Boulder region north of the city, and 1,000 homes in 2 days were destroyed, displacing many children and families, including our own healthcare team members. I'm not a climate expert, but I have definitely seen the profound impact of climate change and natural disasters on stress, distress, trauma, stability, and the health and well-being of children and families. In an article published last May, called Our House is on Fire, Child and Adolescent Psychiatrists in the Era of Climate Change by Dr. Pinsky, Guerrero, and Livingston. They sounded the alarm on how the global climate crisis is impacting child mental health, with children facing more and more frequent and severe weather-related trauma, experiencing climate-related deprivation and displacement, anxiety and grief related to inevitable losses to come. The consequences we see in children and families manifest as acute stress disorder, post-traumatic stress disorder, depression, anxiety, sleep disturbances, nightmares, hopelessness, and sometimes suicidality. These challenges are amplified by disaster-related family and community distress, disruptions in social supports, school closures, and a loss of place-based belonging. Indigenous communities are at heightened risk, faced with the loss of their cultural and spiritual heritage, given their profound understanding to and interconnections with the natural world and our environment. Climate change impacts child and adolescent mental health by intersecting with other factors, influencing emotional well-being and relational health. Some researchers have called climate change an eco-social determinant of health, contributing to and interacting with other social determinants such as poverty, racism, unstable housing, food insecurity, and interrupted access to education and support. It acts as a threat amplifier, exacerbating pre-existing vulnerabilities and healthcare disparities around the world. Southwick has defined resiliency as the process of harnessing the resources we need to sustain well-being in the face of adversity. And they delineate external resources as who supports me, who do I call when I need help, internal resources, what are my strengths and skills, how can I develop them, existential resources, what should I learn from this, what am I grateful for? And I would add ecological resources. What are some of the basic resources I need to live and be healthy and well as provide that for my family? At the beginning of the article, they quote Greta Thunberg, who you all know well. And she says, adults keep saying we owe it to young people to give them hope, but I don't want your hope. I don't want you to be hopeful. I want you to panic. I want you to feel the fear that I feel every day. And then I want you to act. I want you to act as if you would in a crisis. I want you to act as if your house is on fire, because it is. Thank you.
Thank you, Ron Lee. Antoine, I feel like I should be tossing this over to you.
Well, no, we're just, we can go, I think Rupa's next.
Yes.
Perfect.
Okay, hi everyone.
Hey,
I'm
Rupa.
Rupa Basu. I'm the chief of the Air and Climate Epidemiology section at the Office of Environmental Health Hazard Assessment in California. And as an epidemiologist, I conduct a lot of studies on air pollution, heat, and several outcomes, including adverse birth outcomes and infant mortality. I think I'm just going to share a few slides because I think it'll be easier to follow my presentation with these slides. So let's try and see if this will work. Okay. Can everybody see this?
Yes, we can see it.
Okay, great. So let me just play this. Well, it's not really working, but slideshow is not working. But okay, well, I'll just start showing some of this slides. It's not working at all. Okay. Well, I think I'm going to stop share and just go over my what I was going to present in the slide. Sorry. So just studying the health impacts of temperature, mainly heat, we found that it really affects all organs in the body. So originally we thought, okay, this is just a heat-related illness or dehydration thing, but now we're actually finding that it is related to adverse birth outcomes, as I said, infant mortality, also mental health, cardiovascular system is impacted. There's a lot on liver, kidney disease, gastrointestinal diseases. So it really feels like, as we know more about heat, it impacts all organs in the body, including the skin. So, and the way that it's impacted is that for pregnant women, there's often symptoms of dehydration that are very similar to pregnancy. So you might see something like vomiting, and people just think, oh, it's just related to my pregnancy, but it could actually be something that is heat related. And that's important to kind of note because the symptoms of dehydration are often missed and not connected to the heat. What we found in our studies is that not only is there an association between heat and preterm delivery, low birth weight, and stillbirth, but there's a big disparity by race and ethnicity. And this is something that we could address. All of this can be addressable. That's something that I really want to highlight here. With the correct resources, more health education, we can prevent a lot of these adverse birth outcomes. And I would just want to talk very briefly about the reasons for the disparities. So we see that the environmental exposures themselves are actually different by location. So in some communities, I'm really sorry. In some communities, there's just greater exposure of heat or air pollution itself, just because there's more freeways nearby, also fossil fuel combustion areas, and so it's really hard to talk about environmental exposures and health without just talking about why there's a difference in the exposures themselves, right? And so when we're talking about urban heat island effect, that's urban heat is just more pronounced. Also in these communities, there's less ability to mitigate. So that means that there might not be air conditioning, or there might not be the ability to go transport or even know about a cooling center or other ways to cool down. And a big one is not knowing that you're actually at high risk, so that no prevention is taken. And then that leads me to the other side of things. So even without these environmental exposures, we know that preterm birth and low birth weight, stillbirth, infant mortality, all of these outcomes are worse in Black, Latina, and even Asian women. And some of the reasons for this I mentioned is the environmental exposures, but some of it is also on the other end, the healthcare itself, because otherwise we wouldn't see this disparity just with the health outcomes. And part of it is access to healthcare and health education. But even with the same access to healthcare, there's still that disparity. And so there's some differential treatment that needs to be addressed, maybe putting more women, and especially women of color, into these, as doulas, as midwives, as OBGYNs, so they're able to help make decisions. I know I often hear, I was in the room, nobody listened to me, nobody looked like me, and I felt like all alone. So I think those types of things we need to address in order to prevent a lot of what we're seeing in terms of heat and air pollution, which I didn't talk as much about. But that just gives you a little bit of a background on the work that I've done, and I look forward to the discussion. Thanks so much.
Thank you, Rupa, so much. Just to the audience, please feel free to put your questions in for the chat, so as people speak, you can remember them. And then Perinda, I think you're available. I think I saw you somewhere. I'd love to have you jump in.
Yes, can you hear me okay?
We can hear you.
Great. So thank you, everyone. I am Perinda Khatria. I'm Chief Executive Officer at Cherokee Health Systems. We are a comprehensive community healthcare organization in Tennessee. We're both a federally qualified health center and a licensed community mental health center, and we provide integrated primary care, behavioral health, dental, and optometry services to almost 70,000 people in 13 counties across the state. We're privileged to be the preferred healthcare provider of many, and also a safety net resource for those who have no other access to care. We have clinics in urban areas of Knoxville, Chattanooga, and Memphis. We also have sites in the rural Appalachian Mountains of Tennessee and the rural regions that touch the borders of Kentucky, North Carolina, Alabama, and Georgia. We're located in areas that are affected by flooding, tornadoes, and heat waves. These events are occurring much more frequently and with greater intensity, often with significant consequences across our organization for our staff and our patients. So let me just offer an example that just happened recently over the summer. And it is an example of something that is happened with increased frequency. So over the summer, we had a major heat wave in Tennessee. the degree, the heat index was well over 100. And we had to actually close our pediatric clinic for the first time. We had to close it for 10 days. And this was absolutely devastating to our communities and our staff. But basically, our air conditioning system broke down. Our HVAC systems are designed to cool the air 20 degrees during a 3-month summer. Now, they have to run constantly for 6 months because it gets so hot and stays so hot for that long. And also, if you've got a heat index of 120 or 110, and your HVAC unit is cooling the temperature to 90 or to 100, it is still not safe to see patients and be in enclosed exam rooms and waiting rooms. In that one clinic alone, we see 100 children per day. And during this closure, we had newborn babies, and we are the only resource for newborn babies for our Spanish-speaking populations, our new Americans, refugee populations, particularly our populations who live in public housing. We're it, and they could not come for their appointments. We also are the only resource regionally for autism assessments and developmental assessments. They could not come in. The building was not safe for staff. We lost about $20,000 worth of our in-stock medications, and we literally had tons of fans that we had directed toward our refrigerators just for our vaccines. We had to absorb that loss in anticipated revenue. And as a safety net, we don't have that bandwidth to lose. But we were most worried about how do we get these newborns and get these kiddos seen elsewhere. This has become our regular occurrence, is we are watching the weather regularly. When it floods in Tennessee, in the mountains, everything stops. The roads get flooded in the mountains. School buses cannot run. Kids cannot get to school. They cannot leave their houses. It is not passable because you have these very small winding roads. In one of our counties, in Sevier County, where we have Dollywood, when there's a wildfire or a flood, that one county is 280 odd miles of roads up and down, even though it just looks like one county. And a flood somewhere or a fire somewhere basically just stops all systems, access to care. It really impacts every element of life for our staff and the patients we serve. Another issue for us is how connected we are to the system in other hubs. So for example, our phone system and electrical grid is in Nashville, and a storm in Nashville, and this has happened maybe 5 times in the past several years. We cannot, whenever there's a storm in Nashville, which is 3.5 hours from where I am right now, our hearts are just waiting, because a severe storm will knock out that fiber network, and we will literally have no phones for 3 days. And it's not just us, it's the hospital systems around us. So we've gone 3 days with no phones, which is dangerous for a healthcare system. So what our interconnectedness with other cities and other areas because of the power grid or the fiber networks makes us even more vulnerable. So one of the things we've just started to do is focus on a plan for resiliency, climate resiliency, getting backup generators as much as we can. That's a short-term solution. But we are now training our staff and beginning to educate our patients on climate issues and the impact of the environment. And we're working very hard to limit our carbon footprint. We have taken the White House pledge to reduce our carbon emissions. We are stopping paper statements. So we're doing everything we can, but we are still needing there to be much more collective action so we can continue to provide the care that our patients need and our community deserves. Thank you.
Thank you so much, and really appreciate the questions coming in. That'll be really for a great discussion. Malaika, I think we'd love to hear from you.
Thank you. I'll go ahead and share my screen. Okay, is that visible?
Yes.
Okay, great. Thank you for the introduction. Again, I'm Malaika Ludman, and I'm a doula and a certified lactation counselor with Birthmark Doula Collective. And Birthmark Doula Collective and the New Orleans Breastfeeding Center is a birth justice organization that supports, informs, and advocates for pregnant and parenting families. So we offer direct client care, and we also have programs that support and provide perinatal education. So in 2018, we launched an emergency preparedness program called Infant Ready. And the goal of this program is to improve infant, maternal, and community health outcomes during and after disasters. So we promote breastfeeding as an emergency preparedness strategy because we believe that access to human milk provides food security for families. And we also promote safe formula feeding for families that cannot or choose not to breastfeed. And this means making sure that families have access to a steady supply of formula, preferably liquid ready-to-feed formula, as well as the supplies needed to safely prepare it for as long as an infant requires. And the different components of our program fall under different phases of emergency management. In the preparedness phase, we provide training on safe infant and young child feeding in emergencies to emergency managers, shelter volunteers, lactation support providers, and health professionals. And we also do community outreach to educate and prepare families on safe infant feeding options during disasters. So we do this through social media and community events, and also in visits with our clients. And in the response phase, we distribute our emergency feeding kits to help caregivers practice safe infant feeding. And after major storms, we've also activated an emergency parent-infant hotline for affected families. And this hotline is staffed by doulas and lactation counselors with a Spanish interpretation available. And in the recovery phase, which is constant, we are in a process of evaluation to figure out what works and what doesn't in order to improve our program for the next disaster situation. And so this is a picture of our Infant Ready kit, and on the left, you'll see the supplies that are included in it. And we consider these as some of the most essential items for safe infant feeding in the first 48 hours of an emergency until families can access supportive infrastructure. And we chose these items based on thorough literature reviews, conversations with experts, and also with the reality of limited funding in mind. So the kit includes items like hand sanitizer, feeding cups, breast milk storage bags, a cooler and ice packs. There's a nursing cover, also an educational booklet that is available in Spanish and English in one booklet, and that has tips on safe feeding. And while these are all items that we have in our kit, we do want to be clear that any facility or public health agency can purchase these individually and have them in stock to be able to support families in their communities. And I'll briefly just share what our program has accomplished in the last 4 years, thanks to grant funding and donor support, and also wonderful community partners. We've distributed over 800 emergency feeding kits to help families practice safe infant feeding. We've trained close to 500 emergency preparedness and response stakeholders and perinatal health professionals on IYCFE, and we offer both pre-recorded and live virtual trainings. We have activated our emergency hotline 4 times, and we've been able to support over 100 pregnant and parenting families as a result. We distributed donations of clothing and diapers and wipes and menstrual hygiene products to over 200 families after Hurricane Laura. And we conducted 70 rapid feeding assessments of families with young children after Hurricanes Laura and Delta to ensure that families' infant feeding needs were being met appropriately. And we believe that these initiatives can be replicated in other cities and states. And moving forward, we hope to continue this work. So thank you for your time and attention.
Antoine, you're muted.
Thank you so much. Really appreciate that. Thank you guys so much. Really want to get interactive here at this point. So I think we want to sort of drop off now. Diana, do you want to ask the first question? Is Diana still there? Can you guys hear me okay?
Oh, sorry. Yes.
Yes, I can hear you. Do you want to ask the first question?
Oh, sure. Absolutely. I think this is a question. I think it's a question for Rupa. I'm not 100% sure. I was just wondering how much we actually know about the long-term health impacts of climate change on the developing child. I mean, how much has been studied longitudinally about health impacts of, for example, exposure to wildfire smoke or to exposure to excessive heat in infancy. I just don't know. I mean, what is the state of our knowledge here?
Yeah, that's a really good question. So I'll start with the heat. And I know a lot of people always use terms like extreme heat or excessive heat, but one thing I want to say is that in our studies, we found that just the background levels of temperature that we're already experiencing, even in a mild climate like California, is associated with these adverse birth outcomes. So if there's a preterm infant, for example, we know that the long-term implications could be cognitive and neurodevelopmental delays. There could be, we see more cases of things like cerebral palsy, for example. There could be some respiratory issues with the lungs not fully developed. There could also be some cardiac defects or birth defects associated with any of these adverse birth outcomes. And of course, then there's also the chance that, a fetus who's born prematurely could develop just fine. So, just because you see this doesn't mean it is a marker for some of these adverse outcomes, but it means that there's a higher likelihood. So, and then you asked about wildfires too. There's a lot less research done on wildfires. I have seen some wildfire smoke and these pregnancy outcomes examined, and there is an association there. But in terms of long-term risk, we don't know that yet.
So just as a follow-up, I'm just wondering whether one of the agenda items coming out of this task force might be to call for some more research, more longitudinal research, more epidemiological research to really understand the public health impact on young children.
Yeah, I think that would be a great way to go. For heat, I have done some studies on infant mortality, as I said, but also on young children less than 5. And we weren't expecting to see anything there, but actually found a greater association for those less than 5 than we found for the elderly. So even though most of the studies have been done on the elderly, and there's not a whole lot going on with less than 5, like meaning that there's less, this is great that there's less cases, but the cases that we do see have a higher association than the elderly.
Thanks.
Well, that's great information. I have 2 quick questions. Perinda, quick question for you on the infrastructure side. As you guys were looking at the building the heat, how has the local government interacted with that in terms of that? Was it a 10-day shutdown? That's sort of critical. How did they handle that?
Unfortunately, we were all affected. So
Yeah.
I think what happens is it wasn't just us, it was other practices. our buildings are older, they're not climate resilient, all the parts were in back order. HVAC systems, I mean, it impacted the entire region. And so really they were just trying to take care of the basics, even to keep their systems going, to keep their schools going. So that's what happens when you don't have a solid community infrastructure. We're all trying to call the same people. We're all ordering the same parts. We're all rushing out trying to get fans. And so I think this is where, having a coordinated community response is important. And then investing in infrastructure across the board. For us, we are now moving to, we're taking a look and doing a full facility analysis and saying, how can we be more climate resilient, particularly, and certainly every new building is going to be LEED certified. We're going to look at where it is, and getting some of those contingency plans in place. But to be honest, this one, the most recent heat waves this year hit us hard, hit everybody hard, and we were not prepared. So we were just calling each other, trying to get what we can, but it was really a difficult situation at the local level.
No, wow, that's important. And Malaika, really quick question for you. I was seeing the emergency kit was very interesting. Was that as a result of some issue? Were there long-term impacts of not having it? What sort of triggered that sort of development?
Yeah, so the co-founders of our breastfeeding clinic are both nurses and international board certified lactation consultants. And they both had experiences working in shelter settings after disasters as nurses. And so they saw that there were no physical tools or there was no information available in shelters for families about safe infant feeding. So they wanted to help fill that gap. And so that's where the idea was born. We pitched it at an MIT convening called Make the Breast Pump Not Suck. And and the kit received an award. And that's really what launched the beginning of our program, because we got a little bit of grant funding and then things kind of ballooned from there.
Got it. Good marketing piece. Elizabeth, your question. You can jump in and read your question and go from there.
Sure. Thank you. This question came to mind as Rupa was speaking, but I'd be curious to hear from anybody. We've heard a lot of wonderful ideas for what, climate resilience might look like for maternal, baby, and child health. But I'm curious from your perspective, what are the key hallmarks of a resilient system for caring for pregnant people, for babies, and for young children?
I can start with the health impacts. So if we're able to decrease some of the exposure, I think that we'll obviously see some benefits in the outcome too. So until we actually do a study to look and see, does heat and these adverse birth outcomes, is the association lowered after these, these changes that we're making to the healthcare system, or the changes that we're making to the exposures? That is how we could measure it quantitatively. So I'm very, quantitative epidemiologist. That's the way that I would look at this. I know there's a lot of qualitative ways to look at this, but I do want to say that right now, what we're seeing is that there's about a 2 or 3 times higher risk from heat-related preterm delivery in Black and Hispanic women and Asian women compared to white women. So that is, unacceptable. There's no real reason for that. And that is something that we can change.
I jump in with some other thoughts on the resiliency of systems. I'm having this flashback to New York City and Sandy, right? So on a physical plant level, our generators were in the basement, right? So all the power was lost to both of our hospitals. And, rebuild the plan, you have backup generators, you have them not in the flood sort of plain area in the surge area. So there's very concrete things like that, like how do healthcare systems also protect their ongoing functioning in the face of disaster. Right now, we're actually in children's hospitals going through capacity surges here with multiple viral outbreaks from COVID, flu, and respiratory syncytial virus. And we have to dramatically increase capacity, both in our workforce and our spaces, in communications to families and primary care providers. I mean, I think that's what we're seeing in this new era of healthcare, is that you have to be able to flex and pivot on a dime. And, you know, Parinder, you're talking about what happens when there's a flood, what happens when your communication systems are down, or internet, or cooling systems, right? We have to think about those same considerations. And I think the other piece of it is that we really have to invest as equally in crisis and disaster management as we do in prevention and health equity and disparity sort of interventions. As Rupa talked about, the differential impact on different communities, right? So really focusing on what can we do on the front end. As we know, we're in that, and this is the climate crisis, it's impacting kids. I think about it as a child psychiatrist, right? In the first year of life, there are 1 million connections or synapses forming every second, right? In that first year of life, developing the brain architecture for future learning, cognition, problem solving, resiliency skills, and building, right? And so any environmental or stressor at that point, we consider sort of adverse childhood experiences, and those have long-term health sequelae. So really thinking about prevention, promotion, and those foundational things early as we plan for disaster and crisis, I think is important.
Yeah, for us, you know, as a health system, we're really looking at this in terms of components. And I think one thing we've done is we've built in monitoring and tracking indicators, things that we would have never thought of 10, 15 years ago, but we are always watching the weather in certain areas. So that's really important, that it can't be once it's 110 and everything breaks. So we are now, you know, I think the monitoring and tracking mechanisms, having certain indicators is important. I think, like you said, you know, having contingency planning, disaster planning, but we're now preparing for really critical care delivery. So it's not if there's going to be a flood, when there's going to be a flood, when there's going to be a heat wave, you know, do we get our mobile clinic out? And maybe we need to buy another mobile clinic to really be a place when the freestanding brick and mortar clinic just cannot absorb and be there for patients. So we are planning, how do we have continuity of services, assuming this is going to happen again? We know we're going to have heat waves again. And yes, I think the facilities and land usage, it is really important for a nonprofit health system like ours, but I think kind of everywhere, it's not so easy to just rebuild things and just to upgrade all your HVAC units. There's no real funding for that, you know, your roofs, all, you know, window placement. But we are starting to make a facilities plan and land use plan. And I see more and more health centers doing this. And I was in fact talking with a community health center, FQHC in New York, and they just said, we have to start doing this. So here is our facilities plan over the next 5 years to help us be more climate resilient. And then the other piece that we're recognizing is all of those social drivers of health, food insecurity, transportation, those components that are always impacting the people we serve, that becomes to the nth degree. Because when people don't have tons of food in their house, they basically buy what they can the first of the month when they get their check, or when every 2 weeks when they get paid, or every week. And so if you can't go to the store for a week or so, you don't have food in the house. So what are some contingency plans? I'm not kidding. We actually had one of our case managers use a fishing rod to deliver medicine over a creek that had flooded to someone on the other side of the creek because they had no medicine. So these are the things we are just planning for, is how do we keep continuity of services, land infrastructure, and developing good monitoring, tracking indicators. So we can, I don't want to even say get ahead of it, but we cannot be hit so hard with it when it happens.
Well, thank you. Malaika, anything to that before I move on to Andrew? Okay, great. Andrew, you had a good question coming up on your side.
Sure. So, Dr. Liaw, you mentioned that child's internal resources as a component of resilience. Could you please say more about these resources and how we might proactively promote these in order to better prepare the next generation for the adversities that climate change will bring to them?
Yeah, thanks so much for that thoughtful question, Andrew. I felt like there was a huge comment and a question in your text. And I tried to allude a little bit to that in the earlier response, that really I think we have to take a public health approach and offer universal, as we talked about, prevention and health promotion interventions to all kids. I mean, I can't think of a population that is not touched right now by the effects of climate change. I'd really like, is there one pocket, even if we think about it in our country, not to mention the whole world, right, that's not in some way been affected? So universal interventions to strengthen sort of these internal resources would be sort of delivering evidence-based skills and practice and education to kids and families where they live, where they learn, where they work, where they connect. So we're working on interventions and partnering with school districts here in Colorado, as well as with primary care providers, community organizations, to teach those sort of basic mental health, mental well-being, resiliency, coping, healthy relationships, building skills actually, and deliver them not through mental health providers like me, but actually through trusted adults in the community, and really targeting families and communities as sort of the partners in developing those skills that all kids and all families are going to need to weather many, many crises in addition to the climate crisis. I wonder if that answers your question, Andrew. If you have follow-up, happy to answer that too.
Great. Thank you.
Thank you. Thank you. Diana, you had a good follow-up on that.
Yeah, building on Andrew's question, I wondered about, we talk about obviously the resilience of an individual, and we think about the child as or the family even as having resilience or building resilience. I'm wondering about community resilience, and specifically some of the hallmarks of social capital that can help communities, both community members, mutual aid efforts, support each other, and be just simply more resilient in the face of crisis. Wondering how we think intentionally about that work.
And that's to any of the panelists, correct?
Yes, it is. I mean,
Okay.
I think, Dr. Law, it's kind of for you, but it's really for any panelists.
Okay.
I can kick us off, and then I definitely other panelists will have lots of good contributions. I mean, I think about what happened in 2020, right? What happened when COVID shut everything down in terms of social connections, and we were physically isolating and socially distancing from those critical sort of community supports, the social capital you're talking about. It was painful, right? You were like individuals sort of on an island trying to navigate something incredibly stressful. And I think about it from a child and family perspective. Schools all shut down. I think as parents, we didn't realize what a huge part of the child care system schools are, and having to work and figuring out remote work and remote school while not having any help, right? Extended family, community, neighbors. So I think that's a huge area, Diana, to think about social capital, community capital, because usually, especially for natural disasters or heat or other flooding, it impacts the entire community and lots of different communities within that larger sort of catchment area. So I'd love to hear what the other panelists have to say on this as well.
Any other comments?
Yeah, I can jump in and say, just from the perspective of a birth worker, a social connectedness is so valuable to healthy birth outcomes, healthy postpartum outcomes, because of the information, the advocacy, but also just the functional support, helping with meals and helping around the house and helping with older children. Pregnancy and postpartum are very vulnerable times, and in our culture, we've lost turning to our sisters and aunties and our elders for that support, and families have separated, and especially in a climate crisis that's intensified, and people turn to Dr. Google, for answers to things, and feel very isolated. So yeah, just to play on that, just social connectedness is what gets us through.
Okay, great. And Angie, you're next.
Great. Hi, thanks. I appreciated hearing all of the panelists. And I work for an organization that helps finance childcare facilities. So I'm thinking from an physical infrastructure point of view and wondering for Dr. Khatri, what are federally qualified health centers and the systems that fund them and build their facilities doing to ensure just things like more resilient AC systems? And then because families live in their own homes and spend more time in their own homes more than they spend time in the hospital, how are we making sure that their homes are resilient and able to respond, either financial resources or technical assistance resources? I know there's some out there, but I feel like we need to be better plugged into them and how we can advertise them.
Well, we really haven't had that much funding. I think what has happened with COVID is that's where the funding was just, anything and everything we can do to treat COVID, test for COVID, and maintain kind of basic operations during COVID. And so I think we're coming out, of the pandemic stage, hopefully into more endemic. And so we can start thinking about some of those investments. I will tell you that partnerships, we talked about social connections earlier, but a gift of the pandemic, at least for us as a community health center, has been the partnerships that developed, because we had no choice very quickly to form partnerships. So it's interesting. It would take us maybe 1 year. I mean, if we before had to plan a testing event, a year, 2, 6 months, whatever, when you have 3 days to plan a testing event with your grocery store, the gas station, and a local church, guess what? You do it. And so we have developed those connections. And so it is the same for developing climate infrastructure. And also helping our patients. So, we are partnering with nonprofits to help people get funding and to get special education and supports in terms of their housing. And what do we do? Even simple basic things like having insulation. What do you do when it gets really hot? How do you do your temperature control? And so those are just basic areas, piece of low-hanging fruit. We realize it makes a big difference in our patients' lives. And in fact, it can have, as we've discussed, health outcomes, but having a safe place to live, it can make that place climate resilient, but healthier for a child who has asthma. If a child who has asthma and lives in an apartment building that constantly floods and there's mold, more visits with us is not the answer. We've got to address the core issue. So, working with our local utility boards, working with local nonprofits, that's how we've done it. So there's not like one central funding that I'm aware of, but I do think that we are at a place to capitalize and build. We cannot let those really important partnerships and strategies for community impact go after the pandemic. We need to keep them going so we can address these new they're not new challenges, but now that we've kind of got our head out of, dealing with the day-to-day crisis of the pandemic.
Excellent. Any other feedback? I think, Andrew, you have another question.
I think Malaika already sort of addressed it, but
Okay.
Could you comment more on that, the importance of social connectedness for healthy birth outcomes, and conversely, how social isolation is just really damaging to both the mother and the child?
Yeah. I had mentioned just education and advocacy, but also we know that, climate disasters, they're very harmful to the parent-child dyad. Families might be separated from each other and their support systems. They face food insecurity. Their care might be interrupted. They face barriers to accessing services and supplies. So all of that creates disruption and stress and trauma. And we know that, for pregnant people, stress increases the risk of adverse birth outcomes. We know that stress also, on a mental level, it It affects one's confidence in their body as well. So we find that, with infant feeding, a parent might be lactating and breastfeeding wonderfully, but they're under stress after a major hurricane. They see formula being distributed. They don't have confidence that their milk is good enough, and they switch to formula feeding, and that compromises baby's health. Yeah, but having social connectedness and access to information and support can help add an extra cushion of resilience and support for that family.
Thank you so much. Hey, Rupa, I have a question for you. You said something fairly profound, and I'm glad I got an opportunity. You said some of the issues, particularly with socioeconomic individuals, people of color, were preventable, and that's a statement that we should really listen to. Can you say more about that, and what recommendations you would sort of want to provide to this group about things? Because it would sort of seems to me, if something's preventable, we should try to do something about that.
Yeah, that's right. So I think first we have to think about a lot of these health outcomes are preventable, with the right education, with the right care, with the right advocacy for each pregnant woman as they're experiencing any kind of issues related to their pregnancy and following the pregnancy. So I think that we can improve, as I've been saying, the healthcare system itself to be more inclusive of women of all races and offer the same treatment. Because I think that often there's some kind of disparity with what is being offered, based on, whether it's socioeconomic status or just race itself, is something that I think could be improved quite a bit. And then, of course, we could put on the environmental side, some of the work that we do is really thinking about standards for criteria air pollutants or lowering emissions. So that would help everybody, right? If we did this, that would help everybody. But we know that whether we're talking about heat, wildfires, even COVID, that there are disparities, and some communities are just harder hit than others. A lot of the work that we do as epidemiologists is really big picture work, trying to identify these high-risk populations, and hearing about all of the work that everyone else is doing here that really targets, healthcare systems or more individuals. All of those things will prevent a lot of these adverse health outcomes that we've been seeing so far. And I think we need more of this, though. So, like, not every healthcare system, not every person who is, pregnant or thinking about becoming pregnant, or their caretakers are knowledgeable about the effects of heat and air pollution and even the birth outcomes themselves.
Okay.
I just hate to be a Debbie Downer. I'm just going to add in, just for the check, like we did our population health division did a meta-analysis of COVID outcomes and mortality in New York. And it just significantly higher rates of death in our Black and Brown communities, right? And same virus, right? Different living conditions, different access and barriers to care, and the quality of the health system and the care that folks were receiving varied greatly within a couple mile radius from one zip code to another, depending on what you could access, where you could access it. Same thing is true here in Colorado. We have some of the highest infant maternal mortality rates just right outside the boundaries of our high-tech, innovative academic medical center, right, in the zip codes surrounding. And it's if you could get to the care, right, and you had the transportation, as you've mentioned before, and you had the provider, and you had somebody who understood sort of some of the barriers in your daily life to being able to get the supports that you need for a healthy pregnancy or healthy early childhood years. I think it is preventable. I agree with you 100%. To get to that level of prevention, we need some real structural changes in the country and across the world.
Thank you. One last question, and I think this is for Rupa, but absolutely welcome every panelist's input. We talked last time about the fact that the future is discounted at a high rate, and children, frankly, are discounted at a high rate, very young children. Particularly, this is an early years climate task force. We're particularly interested in children from the prenatal to 5 timeframe. Any thoughts or advice for how we should be positioning the needs of children of this time in the eyes of decision makers? I think sometimes people forget the differences between very, very young children and children writ large.
Yeah, that's a really great question. I think that from the epi perspective, when we're looking at outcomes that affect pregnant women, really, we've only been doing these studies for the last 10 to 12 years. And so it's really a new field still, but we made a lot of progress in the field. One thing that kind of stands out is how climate is going to change the effect of health effects in children specifically. An example is with wildfire smoke exposure, we're seeing more acute effects of asthma in children. So to have like smoke exposure and then a big influx of children into the ER and even into the hospitals is something that needs to be prepared for. So we talked a lot about hurricanes and heat and wildfires, but everything is going to present different problems, different risks, and I think also some new exposures and populations at risk. But children especially, I think, often get overlooked. I think pregnant women also, when we're looking at heat advisories, still we're not seeing pregnant women mentioned as being at high risk in all areas. So like I said, if somebody doesn't know they're at high risk, how are they going to take any kind of preventive measures? So I think just being, women and children in general, whether it's epi research or elsewhere, are often the last to get studied. And then once they are studied, there's a lot of barriers to overcome. So I think we're making a lot of improvements, but there's still work to do.
Thank you. Well, thank you, Ronlee, Rupa, Parinder, and Malaika for this really sobering conversation. Antoine, did you want to say anything?
No, just thank you guys so much for your passion for what you do. I'm really excited about that.
And to our live stream viewers, thank you for joining us today. The next public listening session of the Early Years Climate Action Task Force will be on Monday, December 12th at 12 p.m. Eastern. And during that session, we will focus on understanding how policymakers can help the early years sector adapt to climate shocks like extreme